we've kind of gotten used to seeing bigger adults, right? I remember I had a parent bring her son in and say, I think he's got a problem because he's too skinny. And she said, look, you can see his ribs. And the grandma happened to be in there, and I asked her, I go, what do you think? And she goes, that's what little boys used to look like. I mean, that was a profound statement. Here's a mother who thought her son was abnormal because all of his friends had excess adiposity to the point where they couldn't see their ribs when they raised their hands. And grandma noticed, I remember kids looking like that.
Welcome back, listeners, to the PHW Podcast. I'm the host today, Dr. Kristin Marvin, joined by my best friend and colleague. No, I'm teasing. We're just being cheeky after a long day of clinic.
We have had a very long day.
But joined by Dr. Jeffrey Davis, owner of Prairie Health and Wellness, and Doctor Extraordinaire. Everybody loves you.
I don't know about that.
Everybody loves you. Today, podcast number 14. Number 14.
Yeah, that's a lot.
It's a lot. It's good.
I feel like this is a thing now.
It's awesome.
It's more than just like an experiment.
It's a lot of fun. It's a lot of fun. But we are talking about the maybe somewhat to some people controversial GLP-1 medications, right?
Yeah.
So what we hope to do for you guys as listeners today is to get a good foundation established so that you feel more knowledgeable about the basics of these medications. So we're going to go over like, what is a GLP-1 drug, and, you know, where did they originally start? Like, what was the purpose? What were they being used for? Dr. Davis is, I know, going to do an amazing job talking about, you know, how they were developed and what they do in the body, how they actually work. And we'll talk about like the names of some of these drugs, because I'm sure, as we'll get into, you can, get some of them commercially available. But of course, in today's world, there's a lot of compounding going on. So I know we're going to touch on some of those things too. And then we're, of course, going to share examples with you guys of where even we've seen very positive, changes and benefits or clinical benefits with these medications. So let's start at the beginning.
Yeah. So what is a GLP-1?
What is a GLP-1?
Well, so GLP stands for glucagon-like peptide. And I think we should back up a little bit and talk about why was there a push to find a glucagon-like peptide. We knew about glucagon-like peptide because our gut does naturally produce this. It has a very short half-life, so 1 to 2 minutes, and it's out of your system. Just to give you context, most drugs have half-life measured in hours. Some have a half-life measured in seconds, nitric oxide being probably the archetypal example of that. But what we really needed in the diabetic world was, a lot of people, when their diabetes got out of control, we started using insulin. And insulin was an amazing discovery, especially for type 1 diabetics, because they just don't make any insulin, or make very, very little amount of insulin. The difficulty with insulin is it could drop your blood sugar dangerously low. I mean, there's a chance to go into what's called a diabetic coma, where your glucose is so low that your brain isn't operating. And one thing that they noticed with the glucagon-like peptides is it could have an insulin-like effect without dropping blood sugar, which was kind of a momentous discovery. Now, the downside is that it again was metabolized so rapidly, you would literally have to give someone an IV infusion of this for it to be therapeutic, which just in the real world wasn't going to happen. So, I've never really heard the story of how they discovered that there's another naturally occurring GLP-1, and they found it in, of all places, the Gila monster's saliva or venom. I think the saliva and venom are the same, or secreted from the same gland. But the Gila monster is that, it's like I think a Komodo dragon is another name for it. It's a big lizard. Basically. Yeah. And I don't know what researchers decided to say, we ought to look at their spit and see like what's interesting about that. Let's see if there's anything cool in there. But they did, and they found a GLP-1 that was similar to human. I think it shared about half the same amino acid bonds as ours did, but it had a much, much longer half-life. So the half-life being longer meant that you could make it into a drug at that point. So they made this into the drug. The first drug to hit the market. It's crazy to think about this, but it came out 20 years ago.
Wow.
And I remember using this in clinical practice 20 years ago. And that one was called Byetta. And I think Byetta was daily when it first came out. And then they figured out a little change to one of so peptides get broken down like proteins do. Enzymes break them down. The way they got the GLP-1 to last longer was to put a terminal peptide on the end of it that resisted that breakdown. So there's probably a more technical explanation, but that's essentially how it works. It didn't change the ability for that peptide to bind to the receptor where it was going to have its action, but it made it so it lasted a lot longer. And they got better at doing that until I think Byetta came out with a once weekly. So the second one on the scene, I think, was Victoza. But I'd used both Byetta and Victoza. And this was back when I wasn't in functional medicine, but I was kind of clued into, like, most diabetics, what they really need is they need weight loss. They certainly don't need more insulin. I mean, we've shown that in our clinic. We measure fasting insulin in everybody every year. And what we see in people who get closer and closer to being the diabetic is that their insulin just starts going through the roof.
Well, let's pause on that note a little bit and, make sure our listeners really understand, type 2 diabetes, because there are different types of diabetes, but I think what we should at least establish first is like the most common type 2 diabetes, what we call. And so I want the listeners to understand, like, what is insulin resistance and how it develops, and the role of blood sugar regulation and all of these things, because I think then it can really help drive understanding this GLP-1, GLP-1 medications more.
So when we think about diabetes, the term diabetes comes from the Latin to flow through. And this was an observation that I think goes way back to Aristotle, maybe, where patients who had diabetes urinated a lot. And that's a very late stage feature of an uncontrolled diabetic. They have polyuria, polydipsia, so they have extreme thirst, extreme urination. And they noticed that those patients would pee on the ground and I think the way I classically remember this is they peed near an anthill and the ants were all attracted to the urine, right? So there's this classic example in med school where the story is told that this professor is going around and he's teaching these year one medical students, you guys need to be very good observation, very diligent with testing. And so I want you to watch carefully what I do and repeat it. And so he takes a jar of urine and he dips his finger in the jar and he puts his finger in his mouth and licks it. And he's like, okay, I want everybody else to do that too. And people are like, first year in med school, you're not going to say no.
Oh, I'm saying no.
So all the students are dipping their finger in the urine and putting it in their mouth and they're just horrified. And he was like, okay, you all failed because he dipped his index finger in the urine and he licked his middle finger.
Oh, no.
So again, the purpose was to be very absorbent. But that was an example of, that was how people would test for diabetes. They would actually test for sweetness of the urine, like literally test urine. So thank goodness we've got lab tests now that we can do. But I really think the hallmark of diabetes really needs to be told around the story of insulin. And I think insulin is one of the most overlooked labs across in any primary care clinic. If you're not measuring insulin, I think you're really missing out on the driver of a lot of disease and dysfunction. So what's happening is as we increase our intake of simple carbohydrates, our pancreas has to secrete insulin from the beta cells, the islet cells. That insulin's job, there's a lot of things that insulin does, but one of its primary roles is to open up the cell so glucose can come inside. Glucose is absolutely necessary for life, but it's a little bit of a dichotomy because we don't actually have to eat glucose to live, right? So that dichotomy really, or a paradox, I would say, comes down to our liver makes a ton of glucose. And I think Peter Attia is famous for doing the math on this. He's a total math nerd. And he figured out that, like, for the average 180-pound male, that if you could reach into the liver and just turn off glucose production in the liver, not affect anything else, that the average 180-pound male would live 6 minutes before they would die from lack of glucose. So glucose is so important to humans that we do not rely on it from an outside source. So that's why if you're a patient in our clinic, you'll hear us constantly say, protein is necessary, fat is necessary, carbohydrates are optional. So in the modern diet where we're eating highly refined foods, we're getting lots of sugar load, glucose load, we're demanding more of our pancreas. And the pancreas is just like any other organ. If you make it work harder and harder and harder, eventually it can burn out. And one of the problems is the more insulin is going around as a signal, the cells kind of become resistant to the signal. And that can be affected by obesity and weight change. There's a complex interplay that comes in there. But the way I describe it to patients is it would be like if your mom is telling you to clean your room every 5 minutes. After a while, you just tune her voice out and you don't even hear it anymore. We've all had that experience, those of us who has kids, where they tune us out. So the body's being tuned out to the signal of insulin. And then what happens is there's a point where there's a crisis where insulin is so high, then finally the beta cells burn out. You have beta cell dysfunction. And in the background, really what's happened is glucose has stayed pretty stable for years, So glucose hangs in the 90 to low hundreds. And in the background, what's not being measured is insulin's gone from an ideal of 6 to maybe 50, 60, even 80. And then there's just a point where the beta cells basically say, I'm done, I can't do it anymore. Now your insulin drops down to 6, but your diet and your insulin resistance have now made it so that you cannot get the insulin, or the glucose rather, into the cell. So now your glucose is spiking 300, 400. And then after that happens for months and months and months, suddenly your A1C begins to rise. And then when the A1C gets to a certain arbitrary level, we go, aha, you have diabetes. Well, really, we need to look at the hyperinsulinemia picture first. So diabetes type 2 is hyperinsulinemia that's chronic and then ends with beta cell dysfunction and insulin resistance. Whereas type 1 diabetes is where they damage those beta cells right out of the gate, usually an autoimmune attack. Usually happens to kids, adolescents. They cannot make insulin, and so their glucose spikes and they need insulin. It's life-saving, whereas the type 2 diabetic really needs to reduce the amount of insulin their body is making by diet and lifestyle changes. So that's kind of the overview, I think, explaining the difference between type 1 and type 2. Type 1, they can't make insulin. They have an absolute deficiency. Type 2, they have far too much insulin. But unfortunately, we used to treat type 2 by just saying, well, let's just give you more insulin. And we drove insulin resistance even higher.
So tell our listeners then also why is this important? Like, why is this a big deal that when we have high amounts of glucose in the blood that often then correlate? Like, is it really the insulin that's causing the harm, or is it the result? You know what I'm saying?
Yeah. I wouldn't say it's the insulin that's causing the harm. I would say it's the cell's response to the insulin leading to insulin resistance. And the other thing, the insulin, unfortunately, is a growth hormone for fat cells. So if we have excess glucose, the body says, well, are they, is this person doing a lot of exercise? And if the answer is no, then, the body says, okay, well, I got to put it somewhere. So it packs it into the liver. We get fatty liver from that. Right, because the glucose goes to glycerol to triglyceride. Triglycerides get stored in the liver. That's fatty liver disease, actually the number one cause of liver failure right now. Or it gets put into the adipocyte. Adipocytes are amazing. That's our fat cells. They can grow, 100 times their normal size. And the amazing thing about fat is that it doesn't cost us any energy to store fat. It's like having the largest closet you can imagine, or a storage unit somewhere that they just keep adding more and more space and you never get a bill.
Yeah, I had somebody explain it to me once where they said, when you like hop on an elevator and there's a little sign on the elevator that says max capacity, you know, and it gives you a number.
Right.
It's like your body has these little signs and it's like max capacity for glucose is X. Max capacity for fat, infinity.
Yeah.
Like we can only store so much glucose.
2 hours of glucose in the muscle.
Yeah.
But when it comes to fat storage, and that's again, I think if we go back and we look where we historically were as humans, what an amazing adaptive ability.
Yeah.
Right. Carbohydrates weren't readily available, but you would be a hunter gatherer. You'd come across a blueberry patch and you'd eat the entire patch. I mean, you never get the signal to stop eating sugar the way you do with protein. Right. I mean, have a steak and then say, do you want another steak? Rarely you're going to be able to say, yeah, I'd like one more steak. I mean, your body says, that's it. We can't take any more. But when it comes to the tortilla chips, I mean, we just keep shoveling them in. So what is helpful from a standpoint of an acute adaptation becomes a disease when we chronically apply that adaptation, which is what we've done with type 2 diabetes. We just overwhelm the system with more and more carbohydrates. The system becomes resistant to it. We get more and more obesity, which also drives insulin resistance. So that's the driver of coronary artery disease. It's the cause of hypertension. It's the number one risk factor for cancer. Probably the driver of dementia. So when we're talking like some foundational diseases that really have their roots in insulin resistance.
So a combination maybe of we're getting, infinite amount of fat, which is causing inflammation and dysregulation and maybe some of these organ systems that, like you said, fat can get deposited into the liver. And then are we seeing also an inflammatory response from these just arguably higher levels of sugar in the bloodstream? I mean, is that causing?
Yeah. So sugar is sticky. So it glycosylates protein. So the famous example of glycosylated protein, everybody would, if they've had an insurance physical, they check an A1C. So hemoglobin A1C is looking at the amount of glycosylation of the hemoglobin protein. The reason we check that is hemoglobin lives inside the red blood cell. Red blood cells on average live about 90 days. So we can look at that and say, okay, that protein's been around on average for 90 days. How much sugar is stuck to it? We can then back up and go, well, this is probably how much sugar you've had in your bloodstream over those 90 days. Because when you come in and check your fasting blood sugar, you're getting a snapshot of the glucose that hour, what it is. And it's going to change based on the meals you eat. It's going to change on how much sleep you got the night before. It's going to change on whether you exercised.
The piece of birthday cake I ate last night.
Happy birthday. Very nice birthday cake that I saw on Instagram. So that's a very brief overview of diabetes and why it's so important to look at glucose. Our bodies really want to maintain glucose, ideally around 85 on the labs that we get from LabCorp. So,
okay. So let's then give the listeners a few examples then of break it down for them. Because, a lot of our listeners, maybe they're not in the medical field. You and I can sit here and use these terms, right?
Right.
So give the listeners some examples of maybe then what we see clinically, why this is important. What are the either talk about some medical conditions or symptoms or things like that where people can really tie it then together, the importance of this.
Knowing if they have high glucose.
If there's high glucose or just flat out type 2 diabetes.
Yeah. I mean, the hard part is the early signs where we're checking for it in our clinic. It really is a silent, I hate to say silent killer, but it's a silent killer. Until you have, the late stages of hyperglycemia would be you're getting blurred vision, right? Because your lens is now so full of sugar that it's soaking up extra fluid.
That's more late stage.
Right, that's more late stage. You're getting up and urinating all the time.
Yeah.
You're thirsty, right? You're tired because your cells aren't able to get the energy they are because of that profound insulin resistance. Yeah. Obviously, weight gain is a huge one.
Yeah.
Dyslipidemia, right? So your cholesterol is going up. Your triglycerides are through the roof. So the problem is there's so many people in the United States walking around with profound metabolic dysfunction that really don't have any overt symptoms.
Yeah, I think, one example I feel like we're seeing more and more in the clinic or in women, especially perimenopausal women. I have seen some arguably really good fasting labs, but these ladies are coming in and they're complaining. They're like, I have this belly fat that's appearing and it's not a big belly. It's just a little pooch. And they're noticing, my pants don't fit the same. I can just see it. I don't see any definition in the muscles around, my ab muscles, stuff like that.
Right.
So, I, even as a clinician, I've kind of had to take a step back and be like, okay, even though these labs, I think maybe we do sometimes see a lag in the labs, maybe. I think we can see some symptoms. It's just that maybe we've tried to connect it to something else, right? We're blaming another hormone or
PCOS is a classic example. PCOS is really should just be called insulin resistance.
Yeah. I've heard it called diabetes of the ovaries, right?
Yeah.
Or
But skin tags is a sign of insulin resistance.
Skin tags is a good example.
Acanthosis nigricans, which is a dark rash on the back of your neck. It makes, we see that sometimes in kids and parents are like, I keep scrubbing and it won't get clean. It's that's insulin resistance. And we're seeing a lot of obesity. Obesity is probably the biggest, most overt symptom. Sign that we see. But I think we've kind of gotten used to seeing bigger adults, right? I remember I had a parent bring her son in and say, I think he's got a problem because he's too skinny. And she said, look, you can see his ribs. And the grandma happened to be in there, and I asked her, I go, what do you think? And she goes, that's what little boys used to look like. I mean, that was a profound statement. Here was a mother who thought her son was abnormal because all of his friends had excess adiposity to the point where they couldn't see their ribs when they raised their hands. And grandma noticed, I remember kids looking like that.
I knew we had a problem when, we have patients that we're supporting to lose weight that
Yeah.
needed to be lost. And instead of friends and family like being excited and supportive, you've got friends and family that are like concerned.
Oh, yeah.
That are like, are you something wrong with you?
Really worried about you.
I'm
You
worried
look
about
like
you.
you're losing too much weight.
And
Yeah.
so, yeah,
it's a tough
I
one.
think you're right. It's a tough one. But yeah, I mean, I do think that there are some clinical signs and symptoms that we can see. I mean, sometimes I even wonder about when people have fatigue, especially fatigue after eating, or, or even, potentially things like headaches or aches and pains in general.
Joint inflammation certainly could be that. So the hardest part about that weight gain is that once you've gained it, remember there's no metabolic cost for you to carry that extra 10, 15, 20 pounds. It doesn't increase your metabolic demand during the day. I mean, there's a point where someone who is, if they had what we call morbid obesity, where they're 200-300 pounds, there is certainly a metabolic spend that goes on just moving through their day. I mean, if I gave you a 50-pound sack of corn to carry around all day long, you're going to burn more calories as you walk.
Right.
But for the most part, their body's basal metabolic rate doesn't change the more adipose tissue they have. So if you go through a period of time where you're overeating, and then, because we commonly hear people, they'll say, well, I don't overeat. And I say, well, you may not be overeating right now, but you definitely did in the past.
Yeah.
At some point, you went into a very positive caloric balance and, probably a stressful event. It could have happened during the holidays or, extended travel, who knows. But you can go back to your baseline, your basal metabolic rate, and your body says, well, we're burning exactly the amount of calories that we're eating, and it doesn't cost you to keep the fat around. It'll keep the fat around for a rainy day. So you have to put those people in an energy balance where they are in a calorie deficit. And I think that gets us into probably the heart of what you and I have talked about with what are GLP-1s really doing.
Yeah, right. Okay, well, let's move on to that then a little bit. So let's maybe touch back on or go back a little bit, but how do these medications actually work? Like, I know you talked about how it's this glucagon-like peptide, but like, how do we think we understand these peptides? Because it feels weird to call it a drug because it's a peptide hormone, right?
Yeah, and it's actually it's a bioidentical hormone if we want to get right down to it.
Right. So let's get into how these things actually work, or how we think they work anyways.
So the way we think this is working, and I think this is pretty well shown that we have some well understood mechanisms of actions, and I think we have some less understood mechanisms of action. So we understand glucagon-like peptide will stimulate the beta cells to produce insulin. Okay. They also at the same time will block glucagon. So glucagon, normally when insulin gets stimulated, the liver releases more sugar. So this is where I think the magic of a GLP-1 happens, is it says, let's release the insulin, but let's not have the liver release a lot of glucagon, or really it's glucose that comes from splitting glucagon through glucolysis or converting fat and protein by gluconeogenesis. But the end effect is glucose rises when you give glucagon. Okay. Yeah. So we're going to suppress the glucagon while we raise the insulin. And that's essentially going to take the circulating glucose and drive it down. And in doing that, we actually create a satiety signal that goes back to the brain and says, you're full. And that it may be the glucagon-like effect, a suppression effect that has that more so than the insulin. But in doing that, we actually slow the emptying of the stomach. So you're going to feel full faster. I mean, honestly, people can get some of that effect if they just slow down eating.
True.
Right. So if you ate and every bite you took, you put your fork and knife down like we were.
And you chew.
You chewed 27 times or whatever our parents told us. You would slow the meal down enough that satiety signal would hit. But some of us are so busy, we don't even sit at a table anymore. We literally inhale our food. And as residents, we really learn to inhale food because you may have 5 minutes before you have to be somewhere or before your code pagers goes off.
How many people are eating in the car, or they're not even sitting down to eat? They're like multitasking at home or whatever,
Right.
Yeah.
So the satiety signal is really powerful with these GLP-1s. It improves the ability to secrete insulin, which that's the one thing for me that feels a little counterintuitive, is that if we're saying that diabetes is a hyperinsulinemic response, why aren't these GLP-1s increasing insulin resistance? And they don't. And I think it's because their effect is spread out over a time rather than in bursts.
Mm-hmm.
So GLP-1s have a lot longer half-life. And it's, in fact, now the modern ones you take once a week. So you're doing a small injection, sub-Q, once a week.
Mm-hmm.
And you're getting that satiety effect. Now, with that satiety effect comes side effects. So I don't know if you want to go into the side effects now, or we can talk about those.
Let's talk about them a little bit later, because
Okay.
I think we'll definitely get into more some of the clinical stuff that, patients or listeners and patients, of course, will love to hear.
Yeah.
But let's stick on how they work, because I think you touched on some really good points, right? That you said stimulating insulin release from the pancreas, right? When
Blocking glucagon.
The delayed gastric emptying, which
Right.
certainly can give some signals to people, right?
Central signaling back to the brain to say you're satiated.
You're full.
And what's interesting is, so that's one of the less understood effects would be the satiety signals, because there's now some evidence to show that spillover can have an anti-hedonistic effect. So people who have a gambling problem, right? People who have a problem with alcohol, they're starting to see some benefit that when they're on these medications, they don't have that compulsion that they normally have. The way I've heard my patients describe it is that that drive they have to seek food for comfort. Because, we all eat for various reasons. We eat because there's a social reason to eat.
Right.
We eat obviously because we're hungry and we need energy. But a lot of times we eat because we're bored. I mean, that's one of mine is when the kids go to bed, I sit on the couch and finally get some alone time. And I'm like, let me go see what's in the pantry. It's a terrible time to be eating. Like, my body does not need those calories.
Yeah.
So for a lot of people, they say it turns off that
food
kind
noise.
of food noise. Yeah. Great term, right? That says, where it's the refrigerator saying, hey, come check me out.
Yeah.
And people will literally say that they'll go into their pantry habitually and they'll look and they'll go, I don't feel like eating.
Yeah.
And so that there may be some retraining of the brain that happens because, obviously our goal isn't to have people on these medications forever. I mean, especially in our clinic, we're always trying to find like lifestyle changes. But I will say these are powerful, powerful drugs that can help people who are really struggling with weight loss.
Do we think that this is a hormone in the body that we see like naturally decline for people as we age? I know I've heard that question posed before that, that could be, but I don't know if you have any thoughts on that.
Yeah, I don't know. I haven't looked into that one. Yeah, whether GLP or we become resistant to GLP as we age.
Or maybe it's some of those other things, that change, that may be even somewhat more indirect in a way that can set us up for some of this stuff too. Because obviously there's arguably many changes happening metabolically in the body that can make somebody insulin resistant. It's not always just the overeating factor, right? It's
well, and we're starting to see some supplements that are claiming to have a natural GLP effect. And so, I'm curious to see how that industry evolves over time. I think the thing they're always going to be bumping up against is if you're stimulating the body's natural production of GLP, you're always going to be bumping up with that very short half-life.
Yeah. Okay. And then, it seems like you kind of touched on this earlier, but when we can get those types of mechanisms better supported for people, well, then you're going to see some of these other areas, like you said, like maybe changes in cardiovascular risk or changes in some of these other metabolic issues get better.
And this is what I think is comical is that you're now hearing people say that, when people are on GLP-1s, their cancer risk is improving. Their risk of heart attack is going down. And people are saying these drugs are amazing. They're keeping people from having heart attacks. It's not. It's a secondary It's a secondary effect of losing weight, right? It's a secondary effect of the lifestyle changes we're trying to achieve in our clinics.
Yep.
If you're decreasing your insulin resistance, you're losing your excess adiposity, your visceral adipose tissue, right? The fat that's in and around your organs that we measure in our patients every year using the DEXA scan. You're taking the fat that's out of the liver and congesting some of that liver's effect. You're going to improve so many metabolic pathways from weight loss alone. So I think those are all secondary, but they're good. And I don't want to downplay them, but they definitely are beneficial.
They're beneficial.
Yeah.
Another really interesting area I've seen is fertility.
Oh, yeah.
Like women that are struggling to get pregnant. And especially like you mentioned earlier with PCOS and some of this metabolic dysfunction, women are getting pregnant with these medications even. So
Yeah,
far-reaching
fascinating.
effects for sure. For sure. Okay, tell us you mentioned some of them earlier, but what are some of the common GLP-1 medications that people are going to hear?
So the first one was Byetta, then Victoza. Those were approved for diabetes.
Early ones for diabetes,
very early.
right?
Then it's funny. I started noticing early on that my diabetic patients that were doing the best were the ones losing weight. And so on Byetta and Victoza, I saw them losing a lot of weight. And I was like, well, why don't I just start using this in people that are overweight?
Yeah.
So I started using this off-label. Years before it was approved. So Victoza was the first one that sought approval. And what's interesting is the company sought to make a new drug. So they called it Saxenda, but the label said, do not use with Victoza, because it is Victoza.
It's the same thing.
It's the same drug, different name, but they went through a whole different approval process rather than seeking an expanded indication.
Yeah.
And the reason is the price. So when they released that one, it was mainly a cash drug, $1,000 a month. Crazy. And you would think over 15 years that price would come down? Not much.
Jeez.
So Victoza went to Saxenda, and then I think interestingly we have the combos now are the ones that I find to be fascinating. So we now have GLP, GIP. So that's Wegovy, Mounjaro. There's a new one that probably is going to be approved next year. That is a GLP, GIP, and glucagon. So that's a fascinating one. And that the weight loss on that one, they're saying, it could be 40% weight loss. So, you and I've seen these people do kind of get to the point where they plateau on their weight loss, and they kind of get to a resistance point. So some of those drugs, I'm not sure what the commercial name is going to be, but those are something to kind of keep an eye out for. Yeah.
Okay, cool.
There's going to be a ton of these drugs flooding the market because it's literally driving the economies of some of the countries where these are produced, like in Norway, for instance. I think that it has revolutionized just like their GDP can be measured by what we're consuming here.
Medications that we're consuming
in the United States.
That's
and frustratingly, if you're in the UK and you wanted to get on one of these GLP-1s, I think they're around $80 a month. In the US, it's $800.
$800.
Yeah.
Wow.
Yeah, and sometimes more. Right?
Yeah. Okay. I know we mentioned a couple of examples where these medications can show clinical benefit. Is there anything else that comes to mind before we move on?
In terms of other drugs that could show clinical benefit?
No, these medications. We were just obviously talking about like fertility and how we tied it to.
Yeah, I've heard anecdotally, we've started to hear this idea of microdosing. So we should probably touch on this. So the dosing, the typical way that dosing works with GLP-1s is that you keep increasing the dose until you can't stand the dose
side
anymore.
effects.
Yeah, you're essentially, in other words, increase it until you get to a toxic level and then back off or stay there in some cases. So what does toxicity look like with these? Well, it's nausea, it's vomiting. The heartburn on some of these medications can be severe for patients. So there are significant side effects that can happen. There's a certain kind of medullary thyroid cancer that it's contraindicated in. This was actually seen in rat studies at 1,000 times normal human dose. So I don't think we've seen any of that thyroid cancer in the human trials, and certainly hasn't been a safety signal, but it is contraindicated. I would say constipation, fatigue, because some people have such a suppression in their drive to eat that they literally go all day long and not eat, and they're tired because they don't have any energy because they still have some of that insulin resistance that they haven't fully figured out how to unlock their fat cell and start getting into that gluconeogenesis from the stored fat. So some practitioners out there have begun really dialing the dose back. And the hard part with microdosing is you can search for what the dose of microdose is, and there's no definition. And so I would say it's just probably a subtherapeutic dose, or probably a dose under what the industry would typically dose. So one nice thing about using a smaller dose is that, you're paying for a volume of the drug. You're going to go through the drug slower, so it may lower your monthly cost by using a smaller dose. But anecdotally, we've heard of this being helpful for people who have autoimmune disease. It's probably the area that you and I have been most interested in, sort of whether that's an off-target effective GLP-1 that we don't completely understand, or whether maybe insulin's being involved in that, or is the fact that insulin resistance is going down, that we're seeing less inflammation. And so there's maybe some crosstalk with the immune system that's saying, because inflammatory pathway is very powerful for modulating the immune system. So if we're getting less inflammation, some of the fat loss is going to decrease inflammation. So I don't think we completely understand. And there's just, unfortunately, not a lot of trials that are looking at this as an autoimmune treatment. But I think as it continues to be used like that, we hopefully will get more information. These are the citizen scientists that are reporting back to us.
Right.
And again, I think for the most part, it's a very safe drug when used appropriately. And we'll kind of talk about what we define as appropriate use in our clinic.
Well, let's talk a little bit about that now. That's a good segue. But let's first kind of set the stage for, I think when we had patients initially coming to us asking about some of these medications, it was because, they're asking about the skinny shot or, because a lot of like arguably celebrities and maybe some bigger name people in media were like miraculously dropping weight. So
honestly, it was brilliant marketing because again, these drugs have been around for 20 years and been used for weight loss for more than 15, but just in the last 5, you've really started to hear people talk about them. And I think it was the celebrities. I mean, people started really noticing, and then, Hollywood starting to use it, and suddenly everybody wants to be on it. So the biggest fear I have, and probably my biggest critique of the FDA approval process when it comes to these medications is the FDA never required the companies to show where the weight was being lost. Right. So, we do segmental analysis in the clinic, try to do it every year on patients where we do this DEXA scan, body composition scan. So we can tell how much of your body is fat, how much is lean body mass, bone density, things like that. So if, for instance, I give you a drug that you lose 50 pounds of weight, but you lost 50 pounds of bone density, that would be terrible. Right. I mean, you'd be walking around like a fragile egg.
Yeah.
And the reality is, as we've looked at the post-marketing data, those of us who do this kind of measurement, we've seen an alarming trend of people losing both fat and muscle at largely the same rate. And so when you look at the studies on this, these aren't done by the companies that have approved the drugs. They're other studies. Up to 40 to 50% of your weight loss is in lean body mass. Now, the reason that's devastating is that your lean body mass is your metabolism, right? Your resting metabolic rate is defined by how much muscle mass you have. Because contrary to fat that doesn't have any energetic cost, muscle has a very high energetic cost. So the more muscle you have, the more calories you burn at rest, and probably the more calories you burn through activity, right? And you can also soak up more glucose. I mean, there's a lot of benefits to muscle. We've talked in podcasts in the past. But when you're losing weight, my rule for our clinic is that if you lose more than 10% of your lean body mass, we got to stop that. We got to reassess what's going on. So I have had several patients, a handful, I should say, who, as they've lost weight, they are getting fatter. You might say, well, how does that happen? They're losing muscle faster than they're losing fat. And so their body fat percentage on the DEXA scan is going up as they're getting skinnier. What's happening? They're losing their metabolism. When those patients try to come off that drug, and they have a habit of eating a certain way, they're going to find that they are left with a metabolism that's 300, 400, 500, 600 calories less than what they used to burn. And they are going to gain weight back at alarming rates.
Not good.
Not good. Well, depends who you are. You're the drug company, you go,
great.
It's not a bug. That's a feature.
Yeah.
Oh, you're going to be a customer for life?
That's right.
I don't see the problem.
Yeah.
So those of us who are in lifestyle medicine, we're like, that's a
problem.
Huge problem.
Yeah.
So
do you think part of the problem too, is that, I mean, and I certainly don't pose this to try to like push blame on some doctors or providers who are giving these medications, but it does seem interesting to me that, like you were saying, the history of some of these medications, it sounded like, well, that was something you got from your family med doc because you were struggling to control your diabetes, or maybe an endocrinologist because you saw the specialist, for that system. Yeah. But now with these medications, so maybe let's go into this a little bit before we get back to some of the clinical side of things, back to more of the history of the original medications you were talking about, they're commercially available through like your commercial pharmacies,
Right.
but then entered the compounding situation.
So there was a massive shortage that happened, partially fueled by COVID, partially fueled by these drugs were just becoming more popular. Being prescribed more.
Mm-hmm.
There is a clause in the compounding pharmacy rules that says if there's a shortage of a substance, compounding pharmacies can step in and make up the shortfall. So compounding pharmacies did. And so suddenly you saw med spas, cosmetic clinics, starting to prescribe this
online.
Mm-hmm. Yeah. And during COVID, you could have a doctor from, Utah, taking care of your obesity by literally just having you subscribe to a GLP-1
their website type of situation. Yeah.
And I think that's part of it that's being drawn by that. But I think the other part of it is I think there's a lot of family docs out there that know patients struggle with weight loss.
Mm-hmm.
I mean, I myself, it is difficult, right?
Mm-hmm.
I mean, because we just have these habits of eating. I mean, I struggle with weight loss. I think as physicians, we really desire to help patients achieve and have a better life. And so when you have a drug that you're like, well, the drug companies say it's safe and they haven't told you about, hey, make sure they don't lose muscle.
Right.
If you're not clued into that, you're thinking, this is awesome. Look at their A1C is coming down. Mm-hmm. They're losing weight. They're gaining so much confidence. They come in here, they're smiling. They feel great in their skin again. That's an amazing feeling for a provider when you're like, I'm going to do this for everybody. So I think that's driving it, but then you also have the cosmetic clinics that are driving it, and then all the online stuff, which I think expired a couple months ago. So I don't know how those online clinics are doing now.
Yeah,
So
So I think
it's multifactorial about why it's being used so much.
Became very widely available, arguably probably very easy to get. And then, maybe providers not always having some of the clinical insight, the extra resources that we'll get into kind of later on how we manage, more so in our clinic. But I think that the big point is that the accessibility doesn't always equal the best care when it comes to, the nuance that some of these things.
And we're now seeing, one of the reports I read was actually that, and sometimes this muscle loss isn't just skeletal muscle.
Yeah.
But there have been some cases of heart failure now with GLP-1s, which means you're losing heart muscle. Heart muscle isn't something we make more of. You don't go into the gym and pump iron to make your heart bigger.
Yeah.
So I think we will start to see some heart failure that is irreversible, and that's obviously that saddens me.
Yeah.
I don't want to see that. So always, I think with medications, we have to respect that there's a little bit of poison with every pill. There are side effects that need to be respected, understood deeply, and then we need to really understand what's a proper way to use these tools, because in the end, that's a tool, right? And as an integrative clinic, we're going to use all the tools that we have available to us.
Right. So it sounds like these are, who would really benefit from these medications are type 2 diabetics that are trying to, or struggling with glucose control, right? But individuals maybe that would, be put into the obesity category, struggling to lose weight, having other metabolic markers of insulin resistance, things like that, right?
Yeah, the person I would be cautious in using it is the one who's like, I want to get ready for bikini season, because because of half the thing that if every bikini season they're losing 5 pounds of muscle with 5 pounds of fat, and they're gaining it back faster, they're going to be on kind of a destructive cycle. I think.
Of sorts.
I think the place where this makes the most sense is those with the super obesity, the morbid obesity, the ones that are destroying their hips and their knees, their backs are being torn up by excessive weight that they're carrying. It is very, very difficult, again, to get into a steep enough caloric deficit to be able to start shed some of that weight. So I think it's effective in those patients. But again, and I would say in the super obese category, I probably would allow for a little more lean body mass loss, because again, that person is carrying a little bit of extra muscle just to carry the extra weight that they have.
Yeah.
So I think there's some nuance in helping that patient out.
So what I'm hearing you say is this is not a quick fix. This is not a substitution for some of the important lifestyle factors that we still preach and teach, right?
And I would say it is a amazingly powerful tool when used in combination with what we're trying to do with lifestyle.
Well, let's get into that, because I feel like that's definitely more of the approach that we try to take at PHW, right?
So I'll just walk you through like a typical patient. We're going to be obviously checking fasting labs. We're going to look at fasting glucose and insulin, identify hypertriglyceridemia. We're going to correct for essential fatty acid deficits. We want to get all of those things lined up. Vitamin D deficiency, important for insulin resistance. Then we can have the talk about GLP-1s. Once we have a DEXA scan and we can say, okay, how much fat do we need to lose? What's your lean body mass? And most importantly, from that DEXA scan, patients need to understand how much protein do I need in a day? Because if the GLP-1 suppresses your appetite so much that you don't get the protein, your muscle mass is going to go down because your body's going to look for energy, both from fat and from muscle. It can digest your own muscle to make glucose. It can digest your fat to make glucose. Go back to the beginning of the conversation. Glucose, absolutely essential for life, but not essential for us to eat. So we'll typically with a GLP-1 patient, we'll actually have a DEXA scan every 3 months to monitor that. And oftentimes patients will go, I hear you. I'll make sure I work out. When we get that first DEXA scan, what do we see? We see the black line go down. We see the red line go down right behind it. And that's my little yellow flag. Hey, you're losing weight, which is great. You're also losing muscle.
Is that a little bit of almost like a litmus test for you? Because one thing we need to go back even a little bit, even though in our heads, because we practice this way in the clinic, but let's make it ultra clear for our listeners. Before you even get to that GLP-1, you're going through pillars. Yeah, you're doing all your labs. You started naming some of the pillars, but let's really clarify it for patients so they get it.
If I want to set patients up for success and then they're going to use a GLP-1 as one of the tools, obviously we're not going to use it as solo therapy. We want to make sure, number one, you're getting 7.5 hours of sleep, right? You're waking up feeling rested. Eight or more, maybe even.
For some of us.
For some of us need more. We're going to want to be making sure that the food we're eating is good food. I watched a Instagram reel today where this guy was going through a grocery store saying, I'm going to just make a meal with, I'm going to make tacos. And so he goes and picks up some flour tortillas, 37 ingredients. Picks up some taco seasoning, 14 ingredients. He picks up, he's picking up all the ingredients. He's like, this is 179 ingredients for a taco. And so, we're always trying to push our patients towards whole foods. Think about where your meat comes from. We've said it many times on this podcast, but it's more important what your meat was eating than what kind of meat you're eating.
Yeah.
Grass-fed, pasture-raised, regenerative if you can find it and afford it. We want to be eating organic vegetables that need to be organic. If they're, part of the dirty dozen, make sure those are always organic. If they're the clean 15, you can get non-organic versions. So that's our pillar of nutrition. So we have sleep, nutrition, movement, probably the most important pillar when it comes to weight loss. And that's where I really tell patients, you need to have a habit of muscle-centric exercise. So what do we mean by that? So muscle-centric is an exercise that is going to produce an adaptive change in the muscle that leads to muscle protein synthesis. So muscle protein synthesis, the recipe for that is you need to spend time under tension. That tension needs to get close to or reach failure, right? So the last rep of the last set needs to be so difficult that you almost can't complete it, or you complete it and you have no more left in the tank. And then you have to have an adequate amount of protein to fuel the muscle protein synthesis. And I think this is one of the things that's exciting is we know that as you age, there is a resistance to muscle protein synthesis that happens. So the aging non-weightlifting patient actually needs to eat much more protein than a 21-year-old younger patient. So let's say after age 50, you need a lot more protein. However, the caveat is, if that patient is doing a muscle hypertrophy program, right, time under tension that's approaching failure, their protein requirements go back down to what a younger person's are. So they can actually, it's easier for them to eat in a deficit because they're not having to get all this extra protein. So we want to be focusing on the protein intake, right? And so again, it goes back to the DEXA scan. The two flanking pillars we have in our clinic are going to be detox and stress management. Why is stress management important? If you are a stressed out individual where your body feels like it's in flight or fright, you're fighting lions and tigers and bears, oh my, all day long, your cortisol is going to be through the roof. Cortisol is the body's best way to store fat. If cortisol is pinged, your body's like, I don't know what's going on, but we're ready for a blizzard. We're ready for a famine. We're going to pack this fat on. We're not going to let this girl lose anything, right? We've got to get the cortisol down. So we need stress management. We need people to lean into saying no. They need to create margins in their life, create downtime, get away from the phone, go out in nature. All of those things are going to be helping with stress management. On the toxin side, most of our detox pillar, people always say, well, what detox should I do every year? I'm like, first of all, you're detoxing every day. You're sweating, you're pooping, you're peeing. But worry more about what toxins you're putting in your body. And the toxin that we most willingly put in our body as Americans, although this is going down now, is alcohol. And I cannot find a benefit for alcohol, especially in the patient that's trying to lose weight. I just tell them, you got to stop drinking. Got to stop drinking. So we want to reduce toxins from plastics. I mean, you're drinking out of glass. I'm drinking out of ceramic. We're very insistent. We tell patients don't heat up plastic in the microwave.
Fellow employees in the
shot laser beams out of your eyes.
I'm like, oh, what are you doing?
Yeah.
And they're like,
especially the new ones. They're like, who is this freak that's attacking
I'm like,
me?
I promise I care about you. This is why I'm doing this.
So we're trying to reduce our exposure to microplastics. There's so many toxins in our environment. I tell patients you should filter your water in your house, your drinking water. You probably should have a whole house filter because in the shower, even chlorine can be a toxin in high doses. So that's our detox pillar. So we really do, we work on those with everybody. This is critical for the person who's trying to lose weight, because if the body senses that it's not being toxified, that it has adequate nutrition in the form of protein and fat, that you're getting adequate sleep, right? And that you're getting an adequate signal for muscle protein synthesis, that's where the magic begins to happen. And you feel so amazing when you do all those pieces together.
I try to tell my patients, I'm like, you're going to get the best result with this if you do these other things. If you just think you can take these medications.
Or supplements, right? Because I say, but what supplement stack should I be on? Like, well, tell me about your sleep. Well, I get about 4 hours of sleep. Don't even worry about supplements, brother. Like there's none of them are going to matter at this point.
Right. Yeah. So I think that should probably be one of the biggest take homes for our listeners, is that if we want to use these tools, safely, effectively, we can't just use it alone, like you said, as a monotherapy, right?
Right.
Yes.
Yeah. But again, they can be very powerful for turning off that mind chatter, looking for food, the food noise.
Yeah.
So how much protein do we want? Let's get into the nitty gritty on that. So protein should be 1 pound of protein per pound of lean body mass, or you could also say per pound of lean body mass goal. So let's say you're a female, you're at 70 pounds of lean body mass. We really, most females want to be north of 90, unless you're just a very vertically challenged person. You should at least have 90 pounds of muscle on you. So I would shoot for a woman having at least 30 grams of protein with every meal. Why 30 with every meal? Well, there's this new fact that we found out about protein metabolism. The first 20 grams of your protein in your meal actually go to your liver for making glucose, that gluconeogenesis. So the last 10 are available for muscle protein.
It's like you got to pay the bank first.
Right. So you have to pay the bills before you can go out.
Yeah.
So if you're always eating your protein in 20-gram chunks, you're never getting
you're living paycheck to paycheck.
Right. You're never getting to put it in the savings account that actually is going to go toward muscle synthesis. So getting over, getting at least 30 grams. If you're a male, 45, I would say, is probably minimum. Some males need even more than that, especially if you're wanting to gain more muscle mass. So that's the important thing. First priority on all GLP-1s is protein is non-negotiable, because if you are in a protein deficit, you will lose muscle mass, even if you're working out in some cases. So 1 pound of protein per pound of lean body mass. Some people use 1 gram of protein per kilogram of ideal body weight. That's another equation that's commonly used. They actually come out to about the same. And then I really would encourage, if you're getting a GLP-1 from your physician right now, go find somewhere where you can do a full body DEXA scan. Unfortunately, the in-body, the scans that you do where you hold onto the handles and step on the scale, they're not accurate enough for being able to sense whether you're losing that muscle mass. And then really, really encourage people, if you're not in a weightlifting program, you're probably going to lose weight. And with that weight, you're going to lose metabolism. And nobody wants to lose metabolism.
Lose the muscle.
Right.
Yeah. Right. Yeah, I was going to say, I think you're spot on, especially from the nutritional side of things. But I think, gosh, that weight resistance type exercise is a dang near close second, right? Because it's just, Yeah, it's like because you're right. I mean, you can arguably add some muscle on if you're just hitting the protein piece.
Right.
But you're also, if you're not exercising and doing some of these other things, I've seen in the clinic where patients will gain weight, they gained muscle,
Yeah.
but fat came with it, right? Because
Well,
they were
right. And probably what's happening is, again, if they're not doing that muscle synthesis, they have a resistance, which means they have to take in even more protein to make muscle, which means more calories. And you can't eat protein without having some fat, right? So you're getting pretty dense calories in most cases.
Right.
Yeah, as a challenge. I mean, I know it sounds like we're beating a drum here, but
it's so important.
The muscle-centric exercise, that's the biggest lever we have in the clinic to move metabolic health in the right direction.
So important.
Right. I mean, even the active, like I remember I went into the gym one day and one of our former employees was there. He's now in PT school. Matt, love the guy. And I walked in and he guy smiles all the time. You know Matt. And he says, what are you doing today? And I was like, man, I do not want to be here. I mean, it was kind of like how we walked in the studio today. We're like, this has been a long day. I'm tired.
Day, yeah.
And he goes, you know what? Just do 15 minutes and see how you feel. And I thought, I can do 15 minutes. Other 15 minutes, I'll go home. 15 minutes into it, I wasn't stopping. I felt great. And, some of that's that hope hormone that gets released when we move our muscles. I mean, there's so many other things that happen with muscular movement.
That's right.
That I think are beneficial.
That's right. Okay. Well, that sounds like a really good foundation. That's certainly our approach, right? We're really, really driving home the importance of those foundational pieces. And then, okay, let's move on to that next step. Let's say our patients are doing that. They still, we think, can be a good candidate for this medication. So what does that look like? Do we just put them on anything? Do we put them on like the standard dosing? Like, talk our listeners through what that might look like.
So once they've got the pillars in place, they've got a plan for muscle-centric exercise at least 3 days a week. Then we're going to move to dosing the GLPs. I don't want to dose the GLP to the toxic effect. I want to dose the GLP to where we get that brain benefit, where they say, I just don't think about food as much, right? I would much rather have like a slower weight loss on these medications, because I think a slower weight loss is more sustainable. And, hopefully we won't be losing muscle mass, right? So that would be the first step. And that's the thing. I think this is very individualized. Some people are highly sensitive to GLP-1s. Some people are highly resistant to GLP-1s. So some of them we have to use much higher doses. And each drug kind of has a different dosing parameters. So it really depends on which product we use. We might be using a compound if those are still available. In some cases they are. There's some tricks that compounders can get around by adding things in that
like extra vitamins.
Yeah, extra vitamins or nutrients that can keep it in the compounding world. And those tend to be less expensive than the commercial ones. And some people's insurances are paying for it. I mean, talk to your employer. When people complain about their insurance, I tell them, it's the employer that decides what the plan covers. It's not really the insurance company that decides that. That's a per policy decision that's made at the company level. So there's a lot of people in the company that are obese. I encourage them to talk to the HR, because I will tell you, if people lose weight in a proper way and build muscle, the company will spend less money.
That's right.
It's insane how much money we are spending on managing diabetes and the sequela of diabetes, all the other diseases that go along with that. So this can be revolutionary for really reducing the cost of healthcare across the board if they just weren't so expensive. Like if we could get these for the price they are in the UK. Anyway.
Yeah. Okay, good. Yeah. So I think, the big take home point with that is that we try to individualize it. But if anything, 9 times out of 10, we're going to start lower often, right? More of like what you mentioned earlier, kind of more what we call microdosing. But again, there's not like a real black and white when it comes to microdosing. We're just trying to reach what's the lowest therapeutic dose for each individual, right?
Yeah. Well, and let's say you have someone who wants to try microdosing for the inflammatory effect. And you might say, okay, well, you're at an ideal body weight. So if you start losing weight, we know we've dialed it too high. We need to dial back a little bit.
One thing I realized that we didn't really clarify when we were talking about, the different medications that are available, that's probably worth mentioning, is just the different forms. Like you kind of talked about how the common ones are like a once a week injection.
Yeah.
But that sometimes with microdosing, if we're going to go with the injectable options, we might do a very tiny dose, maybe 2 or 3 times a week sometimes, right? And there are some oral right? Oral capsules or tablet versions available.
Yeah. There are oral versions available. I will say I have not had much experience with the oral ones, so I can't speak to their efficacy. My tendency is to say probably injectable is going to be more effective. But again, I think this is what's great about the type of medicine we practice. It's highly personalized. We want to follow up with that patient. We want to understand all the dynamics going into their weight loss journey.
Yeah.
And ultimately, we want to set them on a trajectory that's going to help them be successful for the long run.
Right. Yeah. I would say in my limited experience, I've seen some patients respond well when it comes to kind of the inflammatory piece. They get a reduction in just overall general inflammation with some of the sublingual compounded oral options at lower doses. But from a weight loss perspective, it does seem that the injectable higher doses, I tend to see that a little more compared to with some.
I would agree with that.
Yeah. But yeah, options available, of course, not giving medical advice here on the podcast at all, but just kind of sharing our observations and like what we see in the clinic.
Right.
So good to know that there's different, options for people. Okay, let's then kind of talk through once people maybe get to their goal, like they're reaching goals that they have with using this tool, really working on the pillars, the foundational components from a lifestyle perspective. So then what becomes like that long-term plan or like maybe an off-ramp, plan for people? What does that look like?
I mean, the way I do this is I would dial the dose back slowly as they're getting close to goal weight. Like let's say for a male, we want them to about, again, we shouldn't be talking about this as a weight goal.
Sure.
We should be talking about this as a fat loss goal.
Right.
So we want ideally males to be 18% or lower. Females, 22 would be great. So let's say they get close to that or they're at that point or they're starting to dip below it and there is a point where you start losing fat in your cheeks and you say, I'm looking too skinny.
Want an Ozempic face.
Right. So we would start dialing back the dose. And I think the great thing about how the body is working, especially if they've done the muscle-centric approach, is they will be able to hopefully eat more than they've been eating in the past and not gain weight, right? Because we've reset that metabolism back down. They can go back to what they were eating before. Like let's say they're 60 pounds overweight, but they aren't gaining weight anymore. They are in a eukcaloric state. We're going to pull them into a deficit. We're going to lose that 60 pounds. They will be able to go back to that eukcaloric state they were at before and sometimes a little bit higher. Right, so it'll hopefully be easier to manage their weight going forward. And I think some people are going to have relapse, right? Because again, I think some of those that their eating is driven by that dopamine, right? Where they're just constantly like thinking about food. And I think some of those are going to have to go back on the program. And so there may be some, let's go off of it for 6 months and then see how you are. So again, I think all of that's individualist too. Yeah. Obviously, the drug companies would love if you just never went off of it.
Sure. And, maybe there could be some scenarios where people are doing everything they can. They're really trying to hammer, again, those like lifestyle components. But ultimately, I think, again, it's weighing risk versus benefits. Like, could they be on a low dose?
Yeah. So I think that's where you're going to see people dialing back to low doses or even micro doses for management. And probably those are going to be the ones that are really managing the brain chatter, that food noise.
Right. The food noise.
Yeah.
It's a tough one. Right. Okay. Wow. We've talked about a lot.
Yeah.
What other thoughts do you have? What else maybe haven't we mentioned, or is there anything you want to share that you see clinically, like any clinical like success stories that you've had with it?
I mean, honestly, I've had a lot of success stories. I mean, I know we're hard on the drug industry. I will say this is one of those medications that's pretty slick. The thing that I just keep harping on is I'm so worried about the people that I can see that they're losing muscle mass. And I'm like, this is not going to end well for them. I think there's a lot of people that are going to find that they're going to be very frustrated with the fact that they are weaker. Their bone density is going to start going down. I think we're going to see, manifestations of that later in life. We're going to see a lot more osteoporotic type.
Increased fall risk. Which means increased fracture risk. And I mean, the stats on a hip fracture later in life
after
is
age
pretty
70,
alarming.
50% mortality in the first year after a hip fracture.
That's incredibly high.
Flip a coin.
So I think, when we can sometimes teach patients like, okay, we keep harping on the importance of muscle, but it's like, no, if you could see some of the potentials that do happen to people, right?
Well, and think about our functional movement score that we do,
Yeah.
right? So we're doing an assessment of 13 different movements where we're assessing like what's, hip flexibility and range of motion. I mean, if you're losing muscle mass and you're not able to exercise, that functional movement score is going to go down over time. So don't rob Peter to pay Paul, right? Don't lose weight and not recognize where the weight is being lost. I think that's the biggest takeaway. Whether you're a patient at our clinic, if you're listening to this and you know somebody who's struggling with this, please send them this podcast. I don't want to vilify the approach that they're taking, but I want to give them the tools so that they clearly understand the path that they should be on to have the success that's going to last. And that is going to be the one that focuses on not losing muscle.
Yeah, that's great. I think that's an important thing to encourage listeners and encourage, especially listeners that maybe happen to be our patients, like come in, have these good, honest conversations with us. Like we are not going to, like poo-poo this or make people feel ashamed that, hey, I'm really struggling. Like we struggle with the food noise, like those types of things I think are very real. And I think a lot of people experience them. And, sometimes there's, people or messages out there that are just saying like, it's, it's a willpower issue. Like you should be able to just like, be strict and like do it. And I'll admit, I mean, when I would never say that to a patient because I don't believe obviously in that type of approach. Yeah. But I will admit when I first started learning about these medications and, our brains, we always love to really understand like, why is this working? How is this working? What's the why behind it? That my brain initially was kind of like, well, why can't people just not overeat? Yeah. And I'm
it's
like,
just willpower. It's simple,
it's just a willpower thing,
If only it were so simple.
Oh gosh. Yeah, for sure.
I'm curious, what are your thoughts about them expanding the use to pediatric patients that are obese?
That's a tough one. You know, I mean,
because they're definitely not looking at muscle mass in younger patients.
So I think like my initial thought from just the general perspective out there, where again, I really do truly believe that doctors out there like want to help their patients. They care about their patients. They want to do good. Right.
Yep.
But because of, certain types of like, constraints because of insurance or certain, metrics that have to be met, and you can only see a patient for like 7 minutes. Right. And you got to keep going. I just don't think there's that opportunity to then really talk about what we just talked through, the importance of those foundational pieces and the pillars. But I do.
Because that equally would apply to a pediatric patient.
100%. Yeah. 100%. It's like, man, if we started teaching parents and then children that early and like creating that type of environment, potentially you're not going to need those medications, I think. Right. Yeah. But I do think I'm not going to say I'm totally against it. Because I think if, again, just like how we said with adults, if we can give them the support, give them the education to work on these foundational pieces, but if we still really just need that extra help, I mean, you could change the life of that kid.
Oh, yeah.
From just their
you fix
metabolic
that obesity when they're young.
Yeah. So I'm not going to say I'm like, no, we should never use it in kids, but I think just
tread
like
carefully there.
Tread carefully. And if anything, we just need to obviously prioritize and focus on those pillars.
Yeah,
for sure. But yeah, good question though. Woo. It's a tough one.
We're going to start seeing more of that.
We're going to start seeing it. And I think you're just going to see providers that's just what they're recommending and they're not doing the other things.
Yeah.
So I think that's where the key is.
Right. In fact, I would go so far as to say so far, all of my patients who are on those GLP-1s and aren't doing exercise, they are losing both muscle and fat almost universally. And I would say on the positive side, universally, every single one of my patients that's in a muscle-centric hypertrophy lifting program is losing fat and maintaining, and in some cases, gaining muscle. And so it is again, it's a powerful tool. I know we're harping on it, but I think that's the take home.
Right.
If you don't hear anything from this at all, don't lose muscle.
Right. Yeah, exactly. Okay. Anything else you can think of before we start to wrap up here?
I think we wrapped it.
Good chat.
Yeah.
Good chat.
Thanks.
Per usual.
We got through it.
Thank you. Thank you, Dr. Davis. Thank you to our
Dr. Marvin.
listeners. And don't forget to check out our previous episodes, like you mentioned a couple times. Newsletters come out monthly in our clinic for the past few years now. Providers are writing about really exciting topics.
Can anybody sign up for the newsletter, or do they have to be a patient?
Everybody can sign up.
Okay.
Everybody can sign up. Probably on our website, prairiehealthwellness.com, right?
Yep.
And again, thank you.
Send your podcast to your friends and family.
That's right. And, we social media, follow us on social media and post on social media. Like, we want to hear from you guys too. Like, what do you want us to talk about? I mean, we of course have our list of gazillion things we could come in here and talk about, but we want to hear from our listeners too. So hit up our social media pages, Facebook, Instagram, TikTok, yeah. Can you put, TikTok
We're
for
on
sure.
TikTok.
Yeah. But again, thanks for listening, and we hope you guys learned stuff and took things away from this.
See you guys next time.
Bye.